Grand. Well, good evening, everybody, and welcome to tonight's SWI Health and Wellbeing session. Now, it's not my first time on Zoom, but it's my first time hosting. So I'm really hoping that Charlotte's going to keep me right, deal with all the technical stuff, and then, the rest of it's just going to be grand. Promise. For those of you who are lucky enough not to know me, I'm Susie Finlayson. I'm Federation President for Roxburghshire, and I'm also one of your board members. I'm really looking forward to tonight's session. And do you know this? It's been right lovely to see you all coming in because it feels like ages since I've seen some of you. So nice to see all the friendly faces. We've got this online event tonight focused on a really important topic, women's heart health. And chatting to Amy just a wee bit earlier, she was saying a bit of just general women's health as well. So we're very honoured to have Dr. Amy Small from Chest, Heart and Stroke Scotland join us tonight. And of course, heart health is a critical aspect of overall well-being. And today we're going to delve into some essential tips and insights for maintaining a healthy heart, specifically tailored to women's needs. And we've already found out that red wine is better than Cadbury's mini eggs. So there we go. Amy's bringing a wealth of experience and expertise to this online session as a clinical advisor to Chest, Heart and Stroke Scotland and a practicing GP. Amy's been a driving force in advocating for women's health initiatives. Her dedication to this cause has led to the establishment of invaluable resources such as the Women's Health Cafe, and her work has been instrumental in shaping the Scottish Women's Health Plan. So, without further ado, let's dive into this crucial conversation about women's heart health. And over to you, Amy.
Thank you very much. I will just share my screen. I do have some slides, and I'm happy to take questions at the end so we can really delve into any questions you might have and any topics you want to discuss in a bit more detail. I'm just going to get this on. Sorry. With all the Zoom stuff, I can't get to the. Hang on. Oh, sorry. This was going really well till a second ago. Right, here we go. Hang on. Now, there we go. Yes, so thank you for that invitation and introduction. I'm going to talk a little bit generally about women's health, the Scottish Women's Health Plan, and why we have one. Because I think when I first read the Scottish Women's Health Plan, when it was released in, it was a couple of years ago now, 2.5 years ago, I was really shocked by some of the statistics, which I'm going to share with you, because I think it's really important that we understand actually why we need to focus on women's health and why it's so important. And it might sound daft saying that in a room full of women, but actually when you look at the stats, it can be quite shocking, and it's something I hadn't appreciated. So a little bit about us first and Chest, Heart and Stroke Scotland. So 1 in 5 people in Scotland live with one or more of our conditions. So if you're not directly affected yourself by any of our conditions, you will know someone living with chest, heart, stroke, or long COVID, which we also support now. So 136,000 people in Scotland are living with the impact of a stroke. 180,000 are living with the impact of long COVID. 477,000 people in Scotland are living with asthma or COPD, and 46,000 people are living with heart failure. 300,000 people live with coronary heart disease, and 55,000 people live with undiagnosed atrial fibrillation, which is one of the leading causes of stroke and one of the most common forms of an abnormal heart rhythm. 2 in 3 people live with COPD. 2 in 3 people living with COPD have undiagnosed or an incorrect diagnosis, and almost 1 in 3 people in Scotland have hypertension, high blood pressure, increasing their risk of heart attack, stroke, or heart failure. This is not supposed to just scare you. It is just merely to inform and hopefully to pose some questions for you to think about.
Sorry, Amy, you're not sharing your screen anymore. I don't know if that's intentional.
Oh, it should be. Can you not see it?
Yeah, I can't see the presentation.
Yeah. I've got it okay.
Yes. Oh, maybe it's just me. Sorry.
We've got it.
I've done something while I was trying to do something else.
Can you see it or not? No, not now. Let's try again.
I can't. Can everyone else?
It's disappeared now.
Okay. Let me get it back again. Share screen. I want this one. Share.
That's it.
Oh, and can you see the whole thing there?
Yeah.
Yep, you can see it still. Right, good.
Perfect.
So, this, if you haven't read this book, I can highly commend it to you. It's really fascinating, and it was quoted actually in the Scottish Women's Health Plan. Caroline Criado-Perez has written an evidence-based book quoting stats basically on exposing data bias in a world designed for men. And she says, women are not, to state the obvious, just men. Historically, it's been assumed that there wasn't anything fundamentally different between male and female bodies other than size and reproductive function. And so, for years, medical education has been focused on the male norm, with everything that falls outside of that designated as atypical or even abnormal. So when we think about women's health in medicine, as a doctor, when I was training and further on, whenever we had talks on women's health, it was always related to reproduction and our reproductive organs. It was never about how perhaps our hearts or strokes and things other affect us differently. And so it's just a kind of for you to understand that everything that we've got to date has been based around this. So she really interestingly talks about the fact that most medical trials, for example, will be done on men. So most when we do drug trials, it's usually based on and drug doses are usually based on a 70-kilogram man. So medications that we have that we use every day, bodies and how our metabolism work, but based on a 70-kilo man. So it's just really interesting to know that actually a lot of what we thought we know perhaps maybe doesn't affect women the same way as it should. And in time, hopefully data will come out to tailor medicine a bit better to us after all, we are 50% of the population. So this was the Scottish Women's Health Plan, and it's part of wider work being done across Scottish Government, trying to improve health and reduce inequalities for women in Scotland. It outlines ambitious improvement and changes in areas including heart health, menopause and menstrual health, including endometriosis. And they've set out 66 actions to ensure all women receive the best possible healthcare, which is how we as Chest Heart Stroke have been involved, because it's really made us look internally and externally to what we do with people living with our conditions who happen to be women. So they want to improve healthcare outcomes and health services for all women and girls in Scotland. And we know that women face particular health inequalities and in some cases disadvantages because they are women. So what is health? Health is a state of complete physical, mental and social well-being and not merely the absence of disease and infirmity. I think often we think about it the wrong way round. So why do we need it? Well, women are less likely than men to be prescribed drugs that reduce the chance of having a second heart attack, and women are less likely to receive diagnostic testing such as coronary angiography imaging within 72 hours of hospital admission. So we know that if you go into hospital with chest pain, if you're a woman, you're likely to be diagnosed later, not only because you're a woman, but because of the symptoms that you present with, and then the testing that you need for it will happen later on, and therefore your treatment will happen later on, therefore delaying important care for you. So women make up 51.5% of Scotland's population, but we're less likely to be invited to or participate in medical trials and research. So again, it's that bit about there's just not enough data on us as women and how we respond and to medications and other treatments. And here's some facts just about women's health in general. In the UK, 1 in 3 women will experience reproductive or gynecological health problem at some point in their lives. Despite that, in 2018, only 2.1% of publicly funded research was spent dedicated solely to reproductive health and childbirth. Shocking. You know, so little investment is put into our health and the health of our pregnant women. Endometriosis is as common as women as asthma and diabetes, yet it's something we don't talk about, we haven't talked about, and we know that on average it takes a woman 8 years to get her diagnosis of endometriosis. Poverty rate is highest in Scotland for single women with children, and that has effects on heart disease and the outcomes of that. And women are heavily overrepresented in occupations which tend to be lower paid and undervalued compared to those which are male dominated. I guess I'm telling you part of this because if you go out and do stuff as the Women's Eye, this helps to give you, you know, some evidence and fodder to the work that you do and awareness that you can raise. So over a third of the female workforce is over 50, hence likely to have issues with health conditions. The average life expectancy at birth for women in Scotland is 81 86.1 years, but that can be as low as 75.6 in the most deprived areas and as high as over 88 in the most affluent. It's estimated that 1 in 10 women, yes, I've already mentioned that, so 1 in 10 women in the UK of reproductive age have endometriosis with an average of 8.5 years to diagnose. 61% of unpaid carers are women. And 1 in 10 deaths of women in Scotland each year are caused by ischemic heart disease. So that's angina, heart attacks, and related conditions. Heart disease is the leading cause of maternal death. And part-time employment accounts for 41.2% of women's employment compared with 12.4% of all men's employment. So we're always at that disadvantage. You know, we're economically disadvantaged and health-wise as well. And death from stroke is more common for women than men. That's a complicated one. We think that's probably because we tend to have strokes at a later age than men. So women tend to be older when they have a stroke and therefore have more complications related to that. But also women tend to have a later diagnosis of stroke, so they'll present to A&E, and it takes longer for them, the time that it takes for them to see a doctor in A&E, and then it takes longer from the doctor seeing them to ordering the investigations for stroke, and any delay in stroke then has worse outcomes, and women are at higher risk of that. So heart disease in women. Coronary heart disease kills more than twice as many women as breast cancer in the UK every year, and the single biggest killer of women worldwide. But we still think about it as a man's disease. And it's funny, like when I sit in my surgery and women come to me, women always will come to me very anxious about breast lumps. And they'll come to me anxious about breast lumps from a very, very young age, because I think it's driven into us that we need to be worried about our breasts. That's the one thing I can guarantee you that I will see more than anything about women's anxiety related to their health will be about their breasts. I have yet to find a woman come in, you know, solely worried about heart disease with no risk factors and something to think about for the future. So it's really important that we start to look at our risk factors and what our individual risk is for heart disease. So we know that there are more than 800,000 women in the UK living with coronary heart disease, and 35,000 women are admitted to hospital following a heart attack each year, and that's an average of 98 women per day or 4 per hour. So this is really common. You're going to know someone with a heart disease. You're going to know someone who's had consequences of that. So what are the signs and symptoms of heart attacks in women? So heart attack symptoms really do vary, and we see this a lot in medicine. That suddenly occurs and it doesn't go away. And it might feel like a pressure, a tightness, or a squeezing. Often people describe like they feel like something's sitting on their chest. I get a lot of people coming into me worried about sharp, stabby chest pains, and that's rarely heart related, but central chest heaviness. But sometimes it can also actually feel a bit like heartburn, and it can also make you feel a bit sick. That pain may spread down your left arm, and it can also go down the right arm. I think a lot of us are averse in it going down our left arms, and we don't think about it going into our right arms. And it can spread up into the neck or jaw, through to your back or into your stomach. Classically, people get quite sweaty and lightheaded, and it's often associated with shortness of breath. Some other less common symptoms include like a sudden feeling of anxiety that feels similar to a panic attack. And I think this is the problem where women probably get gaslit in medical settings. They will say that they feel anxious, and we know that women often will be their health problems will be attributed to their mental health as opposed to their physical health compared to men. And the one thing I would say, especially in the NHS now, and you'll know this from just trying to get a GP appointment, is you have to advocate for yourself these days in healthcare. You cannot just be at that point where doctor knows best and people will contact me if they need to. If there's one thing I've really seen change over the 15 years that I've been a GP, is how hard that journey is through healthcare now, because of all the delays, because of all the blocks and the barriers, because the healthcare system is completely and utterly overwhelmed. It's so important that if you think something is wrong, that you shout and you bang your drum and you shout louder until you're heard. And I wouldn't be embarrassed or afraid to do that. And I think that's the problem that many women in particular have. So don't be afraid to speak up for yourself. Other symptoms at the time can be like a sudden rush of anxiety. I've already mentioned that, and panic attack symptoms. And some women can get excessive, or anyone can get excessive coughing or wheezing, which is a funny one. And I have to say, I've never actually done an A&E job, so I've not seen many. I mean, I've had people in general practice have heart attacks, but I've not seen the sort of later stages of it, and this can be one of the symptoms. So what can you do to reduce your risk of heart attacks? I think one of the things that we've learnt more about recently, and one of the things we hadn't really appreciated early on, is actually how important the role of hormones is in terms of preventing heart attacks. So what we know is in your pre-menopause years, your estrogen actually gives some protection against coronary heart disease, which is why women are much more at risk of heart disease after the menopause. We think that estrogen helps to reduce cholesterol levels, and it also helps to reduce cholesterol clogging up the arteries. So there's actually a pretty good evidence base now to show that HRT can be really beneficial in terms of trying to delay that damage to your heart vessels and rise in cholesterol. So, of course, these things are all about risks and balance. But if you have a strong family history of heart disease, let's say your dad had heart attack in his 50s, perhaps your mum also did, or she had angina, I would really be looking, even if you weren't particularly suffering with the symptoms of menopause, you weren't particularly having hot flushes or particularly bothered by things, or you were able to cope with them, I would still go and have a discussion with your doctor or with your GP about what is the risk and the balance and the effects and the benefits of HRT, because actually it might not just be for the symptoms, but actually improve your future heart health. And I think that's something that we haven't really appreciated so much and isn't talked about so much publicly. So as we go through the menopause, the risk rises, and that's also as we get older, the risk rises generally. But then that bit that we as women suffer from is that drop off as the estrogen goes away. And then of course we've got the more classic things in terms of high blood pressure. So now, I've been working in England for a year and a half now, and I've forgotten what heart checks you get in Scotland through the GP. I can't remember if you are invited anymore. In England, you are invited at the age of various stages to get a general check. But if you haven't had your blood pressure checked in the last few years, definitely worth going to get it done. You can get it done at your local pharmacy usually, or you might know someone who has a blood pressure monitor. And ideally, we know that your blood pressure at home will be lower than what it is at the practice. And so often if you go to the GP or the practice nurse or someone and get your blood pressure done and it's a wee bit high, often we'll send you away to your blood pressure at home and do an average of home readings, because we know that we'll get a more accurate basis of an average of your readings at home. And at home, you're wanting that average to be less than 145 over 85. That's the number that you're looking for. And if you're above that number consistently, you really need to be going to have a chat with your GP about why that might be and whether or not you need medication or other investigations to look at that. So high blood pressure is one that's really important. And if we can control your blood pressure well, then we can reduce your risk of heart disease and stroke. High cholesterol. So there's lots of different kinds of cholesterol. We've got good cholesterol and bad cholesterol. We want lots of the good cholesterol, the HDL. And that we find in oily foods, oily fish. We're lucky in Scotland, we've got abundance of salmon and mackerel and all these other good fishes that provide good fats. And also the fats that we get from, your sort of average Mediterranean diet that we like to talk about. So olive oil is a good oil to cook with, although it's so expensive now. I just did my shop today and just I'm shocked by the price of olive oil. But it's cheaper at Aldi. I do need to do that instead. Definitely try to cook with those kinds of oils. And look, and if you are someone that really is either vegetarian or you have issues with foods that have high oily content, you may wish to consider getting omega-3 capsules or omega-5 even. These are ones you can get from the pharmacy or your local Holland and Barrett equivalent type shop. And again, also based on risk factors. So my father had a heart attack in his 50s, so I'm very cognizant that I really need to be careful. And he wasn't a particularly a heavy smoker. He had the odd cigar here and there, but he wasn't sort of your stereotypical chain smoking chap that led to NMI. So I'm even more worried in my case about the fact that my risk factor for heart disease is probably higher than someone whose dad didn't have that. So I'm thinking, I'm now, 43, I'm really looking at my future heart health, and I'm starting to take omega-3. There are various calculations that can be done on cholesterol, and your GP can do that with you if you have concerns related to your heart, your blood pressure, and other factors. So just something to think about. So if you've never had your cholesterol done and you're over the age of 50 and you're worried, it's certainly worth going to have a chat with your GP about that. Diabetes. Diabetes is a disease that causes huge problems with cardiovascular disease. So one of the things that we can do in terms of if we have diabetes is to make sure that that diabetes is as well controlled as possible. Easily said, not also easily done, and I appreciate. But making sure that our sugar control is as best as it can be. And also that we try not to develop diabetes. So being mindful of our lifestyles, which I'll come on to in a little bit about food and on that. Smoking. If there's one thing you can do, more than anything, all those other things put together, is to stop smoking. All the evidence shows us you're 4 times more likely to give up for good if you get the help from an NHS smoking cessation advisor than if you do it on your own. So I'll often say to patients, have you tried giving? Oh, I have given up. I tried, but it didn't work. I said, did you give up alone, or did you give up with the support from the NHS? And the vast majority of people have done it on their own. And I would always encourage people to speak to NHS Stop Smoking. NHS Inform have some really good information on it, and there are links on the website where people can get that support. And if you know someone who's young, who's smoking, who you're trying to encourage them, I always put it in monetary value with them. That's what I do with my younger patients. I ask them how much they're spending on fags a week, and we calculate it. And we always work out at the end of a year they could go on a 5-star slap-up holiday to the Caribbean with their partner for a week, and wouldn't that be amazing? So, I think sometimes we've got to look at these things differently, because a young person can never see forward to the future, and that just isn't something that we know we can sort of predict, but we can think about money. We don't know yet the effect of vaping on heart disease, and I think time will tell. I think that's a concern that a lot of doctors have now, because a lot of young people are vaping who've never smoked. And vapes were designed to help people to stop smoking for a maximum of 6 weeks. So the habits that we've seen, the fads that are going on with vaping, the marketing, etc., all of that is just so damaging. And I really wonder what we're going to find out 10, 15, 20 years down the line about how vaping affects us, whether it's our heart or other aspects of our body, bearing in mind it's all chemicals, isn't it? So having overweight. So I guess I'd talk a little bit about stigma and things like that. We're trying to change our language around people having overweight and having obesity. It is a relapsing, remitting condition. We try to move away from saying that people are overweight or are obese, because that becomes their defining thing, which it shouldn't have to be. It is an illness like anything else. And I think whenever I try to speak to patients, I've learned a lot from a friend of mine who's become an obesity expert, and she always says, always ask a patient if they're comfortable in talking about it, and if they're not, move on. But I think if you have concerns either about your weight or someone in the family, and about their risk of heart disease, we know that the higher our waist circumference is, so if it's bigger than 100 centimetres, I think 100 centimetres for men, possibly 90 for women, I can't remember exactly, but it's that you have a higher risk of heart disease or stroke. I don't like to talk about body mass index, because body mass index is deeply flawed. If you're really small like me or really tall, we know that body mass index isn't particularly accurate or helpful, and if you have a lot of muscle, it's not particularly helpful either. But we really want to look at reducing our waist girth. And that, a lot of that is around what we're eating and when we're eating. Calories are nonsense. There's no point in talking about calories. Everything we thought we knew about food and calories was driven by the food industry, and essentially has been proven to be utter rubbish, if I'm frank. We need to really look at how we eat. So I think we need to move away from the old days of we must start every day with breakfast. Breakfast, most important meal of the day. You know, if you're someone that doesn't want to eat breakfast and you feel happy not to eat breakfast, you don't have to eat. You don't have to eat until you're hungry. And we need to not be looking at low fat foods, because the problem with low fat foods is they're substituting them with sugar, and sugar is very damaging. So actually it's looking more about fiber content, having high fiber, high protein diets, and then moving more towards, again, as I mentioned earlier, you know, having the sort of Mediterranean style diet with olive oil and things like that, but then also eating the rainbow. But it's easy for me to say eat the rainbow when you're living on pennies every week and choosing between heating and eating. I think that's a thing that we are really struggling with in Scotland, and across the UK at the moment, is financial pressures that mean that actually buying 4 pizzas at Iceland for £1 is actually a hell of a lot easier and financially more feasible than eating the rainbow, which everyone loves to tell us in the food, you know, in the food sort of lifestyle medicine section of society. So I guess where possible, try to eat fruit and veg, but the latest stuff shows that actually frozen veg is as beneficial as fresh veg. So that is often cheaper. And just trying to minimize the amount of carbs that we eat and the amount of sugar we eat. So sugar, if we're going to eat it, we eat it as part of a meal, not as a snack. That's the best way to, if we're going to have something sweet. And if we're going to have a snack, have something high in protein like nuts or yogurt. Physical activity is really important. If you weigh 24 stone and you exercise regularly compared to the next chap along who weighs 8 stone and doesn't exercise at all, the bigger person's going to have a healthier heart than the smaller one. So actually, when it comes to heart health, trying to exercise regularly is really important, and do it something that you enjoy. I can't, you know, there's no point in saying to someone go and run 5 times a week if running is the absolute bane of your life. You know, you want to do something fun, whether that's Zumba or I don't know, skipping through the park or whatever it is, something that motivates you, that you want to do. Do it with friends. I find it very difficult to exercise on my own. And actually the latest evidence shows us that any exercise is better than no exercise, and actually not too much high intensity stuff. So we want to do about 80% of what we do on a regular basis should be something that we can do, you know, without being completely shattered on the other side. And at least once a week, that 20%, we need to be getting our heart rate up and out of breath for at least 20 to 30 minutes. But that's kind of what we're looking at. And it's never too late. And I think a lot of people are afraid to exercise if they've had previous heart problems, but actually any exercise is good exercise. And most people who've had heart attacks are now plugged into a cardiac rehab program, which can help show you what's good exercise and what you can do. And I would always just encourage anyone that it's never too late to start. My 80-year-old mother plays tennis several times a week, and she she does way more than I do. She puts me to shame. So I have a lot to live up to. And as I mentioned earlier, family history. So go away. If you don't know your family history, go and ask, because it's so important, particularly family history in people under the age of 60 with heart disease or stroke. That's the bit that's going to really have an impact on your risk factors. And then that will help your GP tailor the individual treatment. Because if I've got someone in their 30s coming to me saying that actually everyone in their family died in their 50s of heart disease and stroke, I'm going to care a lot more about their slightly high cholesterol and maybe their slightly high blood pressure than I am someone who's coming in their 50s whose whole family lived to 105 and never had any problems. You know, so it's very individually tailored, and your GP should be able to have, you know, decent conversations with you about it. Menopause affecting the heart. Well, I've already talked about this already, haven't I? That estrogen protects against coronary artery disease and helps to control your cholesterol levels. As we get older, our blood vessels become stiffer, caused by high blood pressure. So again, we know that after menopause, this gets accelerated, and it increases our risk of stroke or heart disease. So in terms of HRT, because I know people are worried about HRT, what do we need to worry about? Well, women going through the menopause can suffer from really unpleasant symptoms. Those of you who've been through it will know this. It can cause hot flushes, night sweats, and mood swings. It can also cause all sorts of things like skin changes, joint pains, drop your libido, affect your sex life and your relationships. And we know that HRT can be really effective to address quite a lot of these things. And when I have a woman come to me with these problems, they often say to me, how long shall I be on it for? And I'm like, well, it's really hard to know, but rule of thumb for me and that individual, depending on their circumstances and their risk factors, often I'll say till you finish work. At this rate, we'll be 71 by the time that happens. But, we sort of look at if you've got to function every day, that you're getting brain fog from menopause, if you've got to function every day in your job, actually, we need to look at what can we do to help support that. Do we need to worry about blood clots? Well, recent evidence shows us that menopausal women taking HRT have no higher risk of dying from a heart attack than women who don't take HRT. And what we do know is that there are different kinds of HRT depending on your individual risk factors. So women who have issues with overweight or have obesity, we know that transdermal, so HRT that goes through the skin, is safer for them than oral HRT. There are options. And they are definitely worth, if you've ever thought about it in the past and been scared, or you've seen a GP about it in the past. We've learned a bit more now in general practice, so hopefully you can have decent conversations with your doctor. So how can chest, heart, stroke help? Well, I'll just mention the things that we have available, and I'm happy to share these slides because I have put some links on here. But we have an advice line, really amazing advice line team who are predominantly nurses, but we also have occupational therapists, we have mental health workers who work with a team. And if you have heart disease, stroke, long COVID, or respiratory disease, or know someone with it, or have questions, you want to discuss risk factors and you feel like you can't talk about it with your GP, the advice line team are there. They're really, really good. You can either phone them on weekdays in office hours, or you can email them. We've got really good health information on our website, so leaflets about some of the things I've talked about already, and loads of other leaflets about things I haven't talked about. And we have now set up a women's health peer support group. So if you suffer from any of our conditions and you want to be involved in peer support, so speak to other women going through the same conditions as you and the same issues that you're having, you can always get in touch with our advice line who can put you through to that peer support team. We also offer kindness calls. So if you've got someone who suffers from our conditions, who's lonely, who doesn't get out, COVID might have made them afraid or become socially isolated, we do have people volunteers that work for our organisation that can help basically befriend and support people who are vulnerable. We also have a health defence team, so we work out of Maryhill and somewhere else I can't remember now, trying to do, and we're going to start up in Tayside soon, in Dundee, doing health defence. So that's looking at risk factors. So we have volunteers who take people's blood pressure. We can do on-the-spot cholesterol testing, and we're looking at other things like potentially looking for atrial fibrillation screening to look for irregular heartbeats or people who might be at risk of stroke. And we're trying to roll out health defence hubs around Scotland. We also have physical activities. So we've got amazing people who not only do stuff, so we've got wellbeing walks, but we also have online Zoom activity classes, and some of those can be done in chairs. So people who aren't able to get up and around, we can do chair exercises. So if you don't feel able to ask a friend to go for a walk with you, then this is something that you can do from the comfort of your own home, with the support of our staff. And we also have a new scheme, out of hospital cardiac arrest. So if you have ever witnessed anyone have a heart attack, or been involved in resuscitation of someone who has had a cardiac arrest, that whole experience is obviously very traumatic, regardless of your background. And we now support people who've experienced that, again, through the advice line. And there's some really good information on our website about that. And these are various links that I've put on. There's a couple of bits about menopause there if you want to go and read a bit more. And I thought I'd leave enough time for questions and a discussion. Thank you.
Perfect.
That was fantastic. That was really interesting, Amy. Thank you ever so much.
You're welcome.
Yeah. So, do we have any questions at the moment?
I can't.
I could make a statement.
Yeah.
Oh, go on then.
I've had a cardiac incident. I was singing at a funeral and had an episode, shall we say. Stopped singing, controlled my breathing. And I did what women do, because it wasn't typical, Amy. Women don't often present to, I'm an ex-nurse, so yeah. And kept it for a week because I kept saying, oh, it's probably muscular or trapped wind or... And a week later, I had another episode. And the paramedics came out, did the business and said, don't like the look of the ECG. We'll just take a wee trip to St. John's. Peeked in, dealt with, and etc., etc. To muddy the waters, I then got norovirus. I could have had a choice. There was COVID in one half of the ward and noro in the other. So
Lucky you.
And I ended up actually being very ill. So I had to wait. The Royal wouldn't take me because I had noro, and I had to wait for my angiogram. I'm also allergic to local anaesthetic, which complicates things a bit. Anyway, had it all done, no residual damage, and no high cholesterol, no factors at all whatsoever, no familial history. My downfall is the exercise thing. I have severe advanced osteoporosis. Walking is not good, so other forms of exercise. So I've gone back to singing.
Good.
And I go and blast everybody's ears twice a week, and it's absolutely great. So I'm just giving a plug for singing as an exercise. Okay,
we've actually joined forces with Chest Heart Stroke. Have joined forces with the Scottish National Opera, and so that's one of our partnerships at the moment. So we are doing some work with them and doing some singing, because I think that was one thing that really positive thing that came out of COVID, was the work that both SNO and ENO have managed to do with people living with long COVID and the breathlessness that they have suffered. And so I think the English National Opera have pulled out, but SNO continue to do work. And around Scotland, I know there's various different. We've got we work closely with the Chain Gang, there's also the Midlothian Warblers, and there's various other groups who are also plugged into Chest Heart Stroke. And singing is fantastic. So any kind of breathing issues, heart issues, whatever, long COVID, etc. And it's really accessible, and it can be done from your comfort of your own home, can't it? So that's fantastic. But yes, you know, we don't always present, and we are pretty stoic as a bunch, and I think we tend to minimize everything, and we are sometimes our own worst enemies. And yeah, oh, well, that's the other one. So family history of osteoporosis, you know, if you have dependents, then they might want to think about HRT when they're younger rather than older, because we know
they're both on the case.
We know that HRT protects against osteoporosis. So that's another one in terms of if you're looking back at family history, things that you may wish to consider.
Well, I had my menopause when I was 39.
You're right, early, yeah.
And they weren't offering HRT.
No.
I lived a healthy lifestyle, so we decided, the GP and I didn't need it, but we got that wrong.
Yeah. Well, thank you for sharing.
Okay.
Vanessa.
Where are you?
I'm trying to find.
Where's Vanessa?
Struggling to get off mute, maybe. I don't know. You're still on mute, Vanessa. Oh, there you are.
Hi. Thank you.
Hi.
Thank you so much. I really enjoyed that. I was undiagnosed atrial fibrillation, and I think I probably had it for a wee while. The practice nurse diagnosed. I went in with one thing and came out with something else. And when I went in the next day for my ECG, the nurse, I think, nearly fell over. She went straight out to the. She says, "I'll just get the doctor." I says, "Is it that bad?" She said, "Yes." So yeah, the doctor came in straight away. So I've lost weight. I've lost 5 stone in the last 12 months.
Wow, fantastic.
I know. I've increased my exercise. The winter's not been so good because I just walk, because I don't have the confidence to do anything else. My husband always comes with me just in case I collapse or whatever. But I haven't. But the one thing you haven't touched on is, with atrial fibrillation, is vascular dementia.
Yep.
Now, my brain doesn't work like it used to. I worked in the NHS. I was for over 42 years a nurse and a midwife, and retired now because, as I thought, it was stress, but it wasn't stress. It was obviously my brain wasn't functioning properly, so I had to retire because everything I was doing was affected by it, but didn't know at that point, obviously. You know, what else can I do to try and mitigate the risks of vascular dementia?
So I think, so just to explain to everyone, so atrial fibrillation is where the top chambers of the heart don't effectively contract. So the bottom chambers are still contracting properly, but the top chambers are basically fibrillating away. They're fluttering like this. So when the blood comes through, sometimes it can form clots, and those clots get thrown off, and some of them can go into your brain, which is what can cause a stroke if you have a big clot. And if you've got small clots, they block off smaller blood vessels that you might not necessarily see on a scan, but that's what can cause what we call vascular dementia. So small blood vessels effectively affecting the supply of oxygen to the brain that in time can cause memory problems. So it's like all of the other bits. It's trying to make sure your cholesterol's really, really tightly controlled.
That's always been well controlled. I don't know why, but it's always been within normal limits my whole life.
Yeah, blood pressure.
Yes, it's always been within normal limits.
Yeah.
And I check it on a regular basis, obviously.
Yeah, and then exercise. And I think, you know, probably some of your damage will have come prior to your diagnosis. Presumably now you're on blood thinning medication to try and reduce your risk. So again, your risk now that you are diagnosed, and you're on the correct medication to try and to mitigate that, that should keep things, you know, stable, and possibly improve, because we know that over time some of those blood clots can, you know, that damage doesn't have to be permanent. We know even when people have severe stroke, that months down the line they can regain speech, they can regain movement, they can regain so much. So actually those small blood vessels over time may well improve. And it's just difficult to know. I think there's so many things that factor into memory and how well our brain works. So again, it's looking at mood, making sure that mood is good. If there's ever, I have a lot of people that come to me worried about their memory, and often actually it's more their concentration that's poor as opposed to true memory issues. If their mood is low or they're not sleeping well, it's making sure that sleep's really good. Or as best as it can be, and making I can give a whole hour-long talk on sleep, and the importance of that, particularly when it comes to weight and other issues that we know now are so intrinsically linked. But it sounds like you know, you're on the right track. And it shouldn't necessarily have to get worse. That's the difference between vascular dementia and Alzheimer's. So vascular dementia tends to be a stepwise progression if it does progress. So if you didn't have the underlying cause, which at least you know what that is. We didn't talk about alcohol, of course, minimizing alcohol is important as well. But vascular dementia tends to be stepwise bits. So like a blood vessel gets blocked off, and that can then affect one chunk of your brain that can then cause issues. Whereas Alzheimer's tends to be a more steady progress, but although even now we know with that it gets better with gets better but doesn't decline as fast for some people if they're on medication. So I think generally you know, if you've got your diagnosis, you're on your blood thinning medication, you're doing all the other bits, and you're being monitored on that basis, which you will be through your GP, that there's no reason why it should get worse.
Okay. Thank you.
You're welcome.
Okay.
Oh,
Yeah.
sorry.
Oh, Mima's got her hand up.
Oh, yeah, go ahead.
Yep. You mentioned that it was important when you eat as well as what you eat. Would you hold with the theory that you shouldn't be eating sort of after 6 o'clock at night?
So I think it depends on you and your lifestyle and etc. So there's more and more evidence to support intermittent fasting. So with the caveat that if you ever had an eating disorder, well, you don't go down that route. But essentially, it really just depends on you. So what we do know is that if you eat and then move for 10 minutes after you've eaten, your blood sugar levels don't rise as high as they would otherwise, and they come down much faster afterwards. So let's say you have your supper at 6 and you go for a 10-minute walk, that's great. If you then come back and eat a bowl of ice cream and sit on the sofa for 2 hours, your blood sugar is going to go up a lot higher and not come back down as quickly as it should. So I've started brushing my teeth after dinner because that stops me eating anything afterwards. So I wouldn't necessarily say there's a 6 p.m. cutoff per se, but there's increasing evidence that the longer you don't eat, so they say technically about, you know, ideally try to not eat in a 12-hour period, and including in that not having, you can have tea or coffee or water, but no milk in that. So have a clean fast for at least 12 hours, and trying not to eat in the first hour of the day, because again, giving your body time to sort of wake up and use up reserves of energy that's been stored overnight. So I think it's just looking. We know snacking is not great. That's not teaching anyone rocket science, is it? You know, so but yeah, ideally not eating after your supper, and if you can, leaving approximately a 12-hour window after that till you eat again.
Okay, thank you.
Lots and lots of interesting tips for us there.
Can I ask what the difference is between heart failure and a heart attack?
Okay, so a heart attack, so if we talk about myocardial infarction and what people call a heart attack, that's when a blood clot clogs up one of your coronary arteries, so one of the arteries that supplies the heart muscle, and causes that part of the heart muscle essentially to die. And a heart attack can lead to cardiac arrest, where your heart stops. Heart failure is where your heart muscle is damaged and doesn't pump as effectively as it should, and the amount of blood that gets pumped out of your heart isn't as much as it should, and after a while your heart gets larger and larger and doesn't pump so effectively. So often people who've had a heart attack, people who have heart failure may well have had a heart attack in the past that led that part of their heart muscle to die, and therefore their heart not to pump as effectively. And heart failure can cause swelling of the ankles, can cause difficulty breathing, it can cause knock-on effects to the kidneys and other organs in the body, and breathlessness. We are getting better treatments for heart failure. It's not, and it sounds quite dramatic, and I think they are trying to change the name of heart failure because lots of people live perfectly normal lives with heart failure. But for some people, heart failure can be pretty devastating and pretty limiting. And we know someone with heart failure and in the very late stages can have quite a poor quality of life, and often not been diagnosed as palliative when they should have been to have the appropriate support for that condition. So if you, what I would say is if anyone's been diagnosed with heart failure and they haven't fully understood what stage they're at in that and what that means, to go back and have a discussion with their GP, because it is a diagnosis that sometimes is thrown about bit willy-nilly by doctors and not fully explained. We have got some really good leaflets on our website that discuss it, and our advice line team are really good with it as well. So another one that we can discuss further. I don't know if that answered your question.
That's great. Thank you.
Catherine, you've got your hand up. I think you're still muted.
Amy, most enjoyable, really interesting. I think we all wish you were our GP. A question regarding migraine.
Yeah.
I've been a migraine sufferer since I was 15, so long time. It's the only thing I see my GP about, but he really always likes to see me rather than just dish out Zumig yet again.
Yeah.
So I'm guessing, because I've got normal blood pressure, everything's perfectly normal, there is a link between migraine and heart stroke, or is it just a case of a severe migraine can be as debilitating as anything, and they just want to be sure that I'm not just assessing myself as yet another migraine and it could be something more sinister. I'm just curious if there is a...
So there's a few things to say. One thing is migraine is known to get worse after menopause. So unfortunately, that's the one thing that does get worse often. Another thing is and migraine sufferers are at higher risk of stroke. And it sometimes can be hard to tease apart a migraine and stroke symptoms. And the other thing to say, if you're having more than one migraine a month, if it hasn't been explored all the different kind of prophylaxis medication, you probably have, but again, I think a lot of people suffer with migraines unnecessarily. I'm not saying you, but others, and aren't necessarily on the best prophylactic medication, trying to reduce the number of migraines that they have. It's really difficult because some migraines can really mimic stroke massively. You can have a hemiplegic migraine where the whole half body just doesn't function and speech is slurred and all the rest of it, and they're really tricky, and it's really tricky for doctors to pull that apart. And I think you're one of the unlucky ones where because you have migraine, and that will put you at higher risk. But if all the other risk factors then are looked at, making sure that, as you say, your blood pressure is fine and cholesterol, etc., is okay, and you can mitigate all the other risk factors. This is where continuity of care is so important, and having that GP that knows you and knows your story is absolutely vital, and having that same doctor, which is sadly so difficult to get these days. But it doesn't mean you will have a stroke, but I can understand why the GPs want to see you, and especially if it's not your GP that knows you.
Yeah, and again, you're absolutely right, but family history, my sister died at 39 of a brain tumour, ovarian cancer, my mother had a brain tumour, my father was heart. It looks like I'm a walking time bomb if you actually read my story, but the actual reality is I'm just the same with headaches as I was when I was 15. So 50 years later, I do know that they are just part of me. But I just really wondered why, even in this day and age, with struggling to get a GP appointment, they are still so keen to check you out.
Again, so it will boil down to you and your relationship with your GP, and that confidence and that continuity of care, and the worry that the GP will have when they go home at night. Are they going to be worrying about you overnight because they missed something? We live in an increasingly litigious society. I think I feel for me and my colleagues on that front that there's always that overhanging risk of if we miss something, and we would have that anyway, but I think that those risks and the stakes have gotten higher on that front. But where possible, and this is what I try and say, it depends on how your GP surgery works. but I try and I don't know, where I work, people fill in an electronic form and that gets sent to administration, who then sort out appointments. I always say to people, if you're happy, please ask for me, so that ask for a particular doctor, or have two doctors that you know in the practice, that know your story and know your history. And then, and if you're having to request things like Zomig on a regular basis, have all the other bits been looked at fully, to make sure that you should, not needing the Zomig, because there's so many prophylactic options. But I understand for some people that you get them anyway. So
no, it just seems, there is almost a degree of, you feel you're wasting his time, because he's got far more people who are ill.
you're not wasting time.
Something else that's I've had forever.
And I think we need to move away from that fear of wasting time, because I think that's really got people into trouble over the last few years since COVID. I think the press have played a blinder when they keep repeating about how you can never get a GP appointment, and it's actually meant that people are even not trying at times who really should. Your health is important. It's important to you, and it's important to us, and you're not wasting anyone's time.
Thank you.
Any more? Oh, Jackie, are you?
Hi.
Yeah.
You obviously talked about family history, which unfortunately, on my mother's side, the family, they all had heart disease. But are there other health conditions that are mitigating factors? Unfortunately, I have a connective tissue disorder, which I've got Ehlers-Danlos syndrome.
Yep.
So I have problems with my blood pressure at the moment, which I'm getting medication for. But I also have problems with arterial fibrillations and tachycardia. And unfortunately, a few weeks ago, I had a bout of tachycardia that took me to the surgery, and my heart rate was 196.
Ooh.
And I ended up in hospital, and it eventually went down, and I'm now waiting to be seen by cardiology, and it's been 3 weeks. So I know that I'm not trying. I'm an ex-nurse as well. I think we're all ex-nurses here. I'm doing my best to stay calm and do my calm exercises and things like that. But is the likes of the connective tissue disorder, a mitigating factor for the likes of heart problems, or am I just unlucky?
Can I ask you, on your mother's family, were they all smokers?
My mum smoked a little bit, my granddad did, and my aunt and two of her brothers didn't. So there were some smokers and they weren't. But my granddad died in his early 60s, and my uncle had his first heart attack when he was in his 50s. So, and he wasn't a smoker. So it just seems to be the whole family, that side, apart from my gran, she went to 96. She was fine.
Yeah.
But my dad, my granddad, and all of my mum's siblings all had heart problems.
And I'm going to be honest with you. I can't remember the exact links between Ehlers-Danlos and cardiovascular disease. I mean, there are some connective tissue disorders that lead to cardiac abnormalities, malformations. Marfan syndrome is one that rings a bell in terms of aortic issues. I wouldn't be surprised if there's a slightly increased risk, and also Ehlers-Danlos will have been probably in your family as well, because there's very much a genetic link there. But again,
that's actually on my father's side of the family. Okay. So that came from my father's side, but not my mother's side. So,
but again, Ehlers-Danlos or no Ehlers-Danlos, it's about all the other bits, because you can't fix that bit.
No.
We talk about modifiable risk factors and non-modifiable risk factors. There's nothing you can do about that one. So as you are rightly doing, you're modifying all the bits you can modify, and making sure that those bits are as best well you can control. And just because, you know, we have high risk factors doesn't mean these things will happen.
Mm-hmm.
It is just about being aware of them and mitigating the bits that we can.
Yeah.
But yeah, I can't answer that any further than that, I'm afraid.
Okay, that's great. Thank you very much. Thank you.
Right. That anybody else? That's been some amazing stories we've heard tonight from you all, and hopefully lots of information imparted. I'm counting myself lucky that I feel okay at the moment, although my dad's had triple bypass and my mother's on her second pacemaker, but okay, I'll keep going for now. If that's all our questions, I don't see anybody else waving hands at me or anything. I'd like to thank Amy. That was absolutely fantastic. Really, really interesting. I had no idea we had a Scottish Women's Health Plan.
Yeah.
I'd never heard of that. So there's some really, really interesting stuff in there. And I think, yeah, maybe if you are able to share your slides via Charlotte so that we can get those links and things for anybody who's interested, that would be really good. So thanks everybody for coming along tonight. Thank you, Amy, for giving up your time. We've got another, just so that you all know, I'm sure you all do, you're probably all signed up already, but we have some Skillshare coming up on the 13th of March. I'm not sure how well this goes down after talking about heart health, but this is a perfect frangipani tart bake-along session. But you know, we all need a little treat now and again.
Everything in moderation.
Absolutely, absolutely. We've also got one of our SWI stories with our founder, Catherine Blair, on the 20th of March. And I think the next health and well-being session is from the NHS breathing space. And I'm sorry, I don't have the exact date of that, but it's about the end of April, I think, sometime. It'll all be on the website, and Charlotte will be sending us out information, I'm sure.
Yep.
Thank you, Charlotte.
Also, there'll be a little survey that goes out because we do take all your feedback on board for future events. So if you have a spare minute, just fill that out. That'd be great. And what we usually do is everybody unmutes
and clap,
and we can give Amy a big round of applause.
Absolutely.
Thank you very much.
Thank you.
Thank you. Thank you for having me.
Oh, thank you.
That was excellent.